So it's entirely up to you. So if you want to turn your cameras off, you can do. People may still be able to see your names, etc. So it's just to make people aware of that. And it looks like Francis has just started the recording. So, okay, so just a warm welcome to everybody for joining us today. The purpose of today's webinar, morning Anne. Hi. The purpose of today's webinar is really just to provide you with a bit of an update on the supply and distribution work stream. And I'm just going to introduce myself first of all. I'm Nikki Morton and I'm the lead for the National Wound Care Strategy Programme Supply and Distribution Workstream. I'm just going to hand over to Anne and Ken. Maybe Anne, are you okay to go first and just introduce yourself as well?
Hello, my name is Anne Jacqueline and I am the Digital Data and Information Lead for the National Wound Care Strategy Programme. And sorry, I'm moving house, so there's furniture coming in. So I do apologise for doing 2 minutes late and not being on my game. I'll now settle down. Thank you, Nikki.
Not a problem, thanks Anne. And Anne will be keeping an eye on the chat as well with Ken to hopefully answer any questions. So over to you, Ken. Do you want to just do a quick introduction as well?
Yeah, certainly. Good morning, I'm Ken Dunn. I'm a retired burns and plastic surgeon, but the reason they keep me on in the National Wound Care Strategy Programme is because I do technical things with data and work with Anne and Nikki on this programme. Thanks.
Thanks, Ken. That's brilliant. Right, I'm just going to share my screen if that's okay, and we will get cracking. Can everybody see?
Yep.
It's always worrying at this point, does the technology work or not? So it would be great if everybody could be on mute, but please feel free to put any questions as we go along in the chat. And there will be a pause about halfway through where we'll answer questions on the first half of the presentation. And then there will also be opportunity for more questions at the end as well. So we'll try our best to answer those for you. So this is just really a bit of an update on the supply and distribution work stream, where we're up to and what we're doing. So without further ado, we'll get cracking. So just a bit of a refresher, really. What is the problem? What is it that the National Wound Care Strategy Programme is all about? And really, the programme started a couple of years ago now, looking at the issues around wound management, specifically around pressure ulcers, lower limb wounds and surgical wounds. And why is it doing it? Well, we know that the cost of wound care in England is already high, but rapidly increasing. We know that too few patients are actually receiving evidence-based care, and that's been borne out by many studies of current practice. Lots of poorly organised wound care pathways as well, and certainly just taking time to sort of take a step back and study and examine those care pathways, it's not difficult to see why sometimes patients can get lost within those pathways. And we know that there's a lack of data and information, good quality data and information to actually inform quality improvement. So the National Wound Care Strategy vision is really about improving the knowledge and skills, so through education, but also improving those systems and pathways for the delivery of care. And really importantly as well, to improve the quality of data and information. And that's really probably the main area where the supply and distribution part of the programme fits. So what do we actually mean by data and information? And obviously there's patient data, workforce and productivity data, but what we want to focus on probably from the perspective of supply and distribution is that product data. So wound care products, where do we get them from? How can we get them to the patients efficiently and effectively? And also equipment, which we will be moving on to that area as well. So we know that a lot of the information that's collected at the moment at clinical level is really there to it's a bit of a one-way street, so it goes forwards and informs business in terms of commissioning and contract management, but there's not a huge amount that comes back in and supports that continuity of care and decision support at the point of care by the clinicians who are inputting all of that information. So this is really looking at how we can get better at using that information, putting information in that then helps with, particularly with things like clinical decision support. Okay, so when we're looking at product data and information, what are the current issues? So we know that wound management products are currently obtained by lots of different routes. Very often those will have different types of coding associated with them, and that means that it can be really difficult to examine wound care product use in a particular area. We know that several wound product classification systems are in use and that they differ quite significantly, and no single system can actually provide the data that we require. So the National Wound Care Strategy Programme was asked to develop a new classification system by the Department of Health and Social Care and NHS England, and that's one of our key areas of work that we're working on. So why do we need it? As I said before, we know that names of individual products, product groups and subgroups are all inconsistent. We know that most of the classification systems that are out there tend to be hierarchical, so lots of different tiers or product groups and subgroups, but they don't necessarily match across the different routes of supply. So we know that that hierarchy differs, and we know that we can't map them necessarily effectively to merge that data and get a complete picture of what's happening. So just a bit of an example, and this is probably one of the simplest examples and least controversial, but when we look at the BNF and NHS supply chain framework or the SDMA classification system, a simple film island dressing is classified in different ways in different systems. So in some it might be in the advanced wound dressing section, in others it might be in general wound care. So lots of differences in terms of how these are classified. So what do we want to achieve when we look at this new classification system? So we definitely want to achieve the parity in coding by mapping the existing codes across these different systems so that we can actually look at product use in a meaningful way. We also want to identify those factors that differentiate between the products, because some products are quite similar and others are quite different. And in order to facilitate clinical decision support, we really need to be able to differentiate between the products. So the classification system needs to unify all of these previous systems and hopefully provide an overarching product classification system that'll be a repository for all products that are listed on the UK market. So we always try and get this particular slide in because there's always a few misconceptions about what we are doing and what we're not doing. So what are we doing? We are reviewing the current routes of supply, or actually we've done quite a chunk of that work and published that on the website in terms of current routes of supply for wound management products. And we'll talk a bit more about that in a moment. We are also developing this wound product classification system that hopefully, when it's finished, will be able to be used by all organisations who either procure, list or supply these products. So what are we not doing? And this is where the misconception developing a national wound product formulary. Absolutely not. We're not restricting access to products and have no intentions to do that. We are not involved in procurement frameworks. So it's just a bit about what are we doing? What are we not doing? So what are we doing? We're going to talk a little bit more about those two in more detail. So the review of routes of supply, routes for supply and distribution of wound management products. We're going to just talk about that one first, and then I'll pause for some questions around this, and then we'll move on to the classification system. So expenditure on wound management products. We know that in 2021, which probably isn't the best year that we could have chosen to look at this, because obviously that was the year that we had COVID as well. But the estimated cost of wound care products was around about £254 million. And that was broken down by FP10 prescription. So we know that a lot of care for people with wounds takes place in the community. And a lot of those areas still continue to use FP10 prescription. So around about 154 million went through that route. For NHS supply chain, it was around about 96 million, although they did say that they felt that those figures were slightly lower than usual because of COVID. So there were disruptions caused by COVID to the supply. And then NHS shared business services also around about 4 million through their wound care frameworks, which is also another NHS framework that's available. But we know that there's also additional spend via online ordering platforms, perhaps where they go direct to the company, and also local commissioning arrangements, which we can't necessarily see at national level. We also know that there's some products are ordered, particularly in the acute setting, via non-stock ordering, and that is listed with the NHS Digital Spend Comparison Service. And we know that there's some spend through hospital pharmacy as well. And we're working with the team at RX InfoDefine around that source as well. So lots of different areas of expenditure, but that's around about what we know about at the moment. So the review of routes of supply, and as I said, this is available on our website at the moment. It was published in November, earlier in November. So it's there if you want to go and have a read at it. What we really talk about in here is prescription routes and purchase routes. So we break that down into community and primary care, FP10 prescription, and also hospital prescriptions, both internal and the FP10 HPs. We also look at purchase routes, so things like NHS supply chain framework, other NHS frameworks like SBS, and also local tender or commissioning arrangements that might be in place, and independent purchase, because with the move to possibly self-care as well for some people. So what's included in the review? So for each of these routes of supply, we tend to look at where the products are listed, how they're ordered, some of the implications for patients, the workforce and clinical practice issues associated with that, quality, healthcare systems, audit and financial management, which perhaps is where the data comes in, and sustainability. And we provide some worked examples as well of how that actually works in the real world. So just to conclude on the routes of supply, before we move on to the classification system. So wound care products form a small, and although it looks like quite a large amount of money that we spend, it's a small but important part of the overall costs associated with the provision of wound care. So we know that the wound care products only form one part of that, and much bigger costs associated with pathways of care and the workforce implications around with people with wounds. So really the big costs come from the people. But it's still important to be able to look at it, particularly in the current climate. It's also important to consider the different routes of supply to optimise patient experience and outcomes. And we often talk about reduction of waste, which is a really important one. We know that there's huge wastage sometimes focused around wound management products. So we need to get that best possible use of NHS resources. And it's also essential that people with wounds can actually get the right wound care product at the right time and in the right place. And, you know, over the past few years, lots of work's been done around that. But whatever route of supply is used, we know that the integrated care systems need to be able to quantify the volumes and types so that they can actually look at the types of products used in their area. And we know that a lot are already trying to do that, but it can be quite fragmented at the moment, trying to look at all the different routes of supply. So we're hoping that this document will help people to be able to look at it and determine perhaps which route of supply is most appropriate in their environment that they work in. Or it might be a hybrid, it might be different types of routes of supply that are used. I'm just going to pause there and just ask Ken and Anne if we have any questions.
There have been no questions posted in the chat.
Okay.
So unless anybody wants to post something now or stick their hands up, I think this is the point where we say speak now or forever hold.
Okay.
I think it was comprehensive, and as you said, it's been previously published. So I think we're safe to go on, unless Ken, you want to add anything at this point.
No, there's nothing I stick in now. Thanks.
Okay, so we're good to go. Yep. Okay, so this might be the bit that most people have signed into this webinar for, really, which is the development of a new wound product classification system. And we're just going to really take you through our journey with this and our journey so far and where we're going to next with it, and hopefully clarify some of the issues around it. So our principles that we've sort of based this work on around the new product classification system is really about looking at and building on and sharing with the existing databases. So we know that there's lots and lots of big listings of wound care products, which are sometimes very often very different. So we're looking at these databases such as BNF, the Drug Tariff Part 9, the GMDN, or Global Medical Device Nomenclature Agency, also apply codings and have lists of products listed with them. The MHRA, in order to have a wound product and to be able to market that within the UK, you have to list that with the MHRA, so they have their own listings. And one of the mandated requirements for that is the GMDN number or code, GMDN code for that group. NHS frameworks, so we talked previously in the routes of supply about NHS supply chain, NHS SBS, etc., and also suppliers and manufacturers. So lots and lots of different databases exist, and what we really want to do is build on some of those and really pull them together to get one version. So we want to be able to support digital clinical decision support at the point of care. That's really our ultimate goal. And we probably made this more complicated because what we've looked at is around about 100 different attributes that we feel that if those are classified, then that sort of almost puts the products into the right buckets, and you'll hear us talk about buckets probably various times during this presentation. So what we need to be able to do is support that product use review as well, irrespective of the route of supply, because hopefully they will all be in the same bucket, and develop a prototype for handing over to a host body to manage this at the end of the time, because the National Wound Care Strategy Programme is time limited, so it's a 5-year programme. What we're trying to do is develop this, but also develop the prototype to hand it over so that it can be managed in the future as new products come onto the market as well. So just a bit of an extract from the current database as it stands. So we've got things like dressings, bandages, hosiery, etc. And some of the ingredient buckets that we've used, like hydrocolloid, gelling fibre, hydrogel, foam, etc. So there's just an example there. This isn't all of them, but this is just some. And then we can see very quickly the numbers ramp up. So 31 different product lines for hydrocolloid, but then that equates to 198 product formulations So for just dressings and bandages, before we even get into hosiery and lymphedema and other areas, we're looking at around about 1,000 product lines with around about 7,000 product formulations. So a big piece of work. This is quite a busy slide, but it's just to show you sort of where we're at with this at the moment. And probably most importantly, this is just showing how the database is sort of constructed really at the moment. And one of the more recent things that we've looked at is this sort of issue of static, specific and dynamic attributes. So the ones at the top are fairly static. They can be populated with the information that we already have. The ones in the middle are more specific and they will require some element of pre-population or will be populated from the various sources that we've got, and then the dynamic ones as well. So I'm just going to move on to the next one. So we talked about these 100 attributes and we've tried to break these down. So a lot of these are the technical attributes. Some are coding related, which we've talked a little bit about, and the differences in coding. We also have clinical attributes, and those are the three main areas that we're working on at the moment. So we're not really, well, we won't be doing anything around the localization. Those factors are, or those attributes are within this system so that when perhaps in the future it gets picked up and put into a wound management digital system, for example, it will be able to be localized to that particular area's local formulary so that they will be able to access that, just the products that are on their local formulary. And the supply cost and pack size, etc., that will be completed later on in the process. So the three areas that we're really focusing on at the moment are the clinical, the coding and the technical. So in terms of the coding, a lot of this is actually moving ahead quite speedily at the moment. So we've got all of our data sources and Ken's been doing fantastic things with the database, and that is really moving forwards very quickly. In terms of the technical attributes, we did receive a lot of information from industry. Some of that was more complete, some of it was less complete. So we are also mapping between existing data sources that we've got to try and complete some of the technical attributes. I already talked about supply and localization fields, so I won't go into those too much now. But the clinical one is probably the one where it's perhaps more controversial, and we really need a really good, robust approach to our methodology for assigning these clinical attributes. And that's where we've been investing quite a bit of work recently around that. So what are some of the challenges that we faced with the clinical attributes? And really this classification system, we want it to be for the NHS, as I said before, for the NHS, by the NHS. So in order to do that, we really need to understand both the similarities between products, but also we need to understand the differences where they exist. We know that there are British standards for attributes such as absorbency and permeability of dressings. However, that still can lead into difficulties because independent testing is not mandated. Therefore, industry can use independent labs or test the products in-house. So we do know that, and a lot of you will be aware of the Surgical Medical Testing Laboratory, SMTL. They were actually commissioned back in 2016 to 2018 by NHS England to provide some independent laboratory testing of a whole range of products, which at that time was subjected to this independent clinical review. And some of you will have seen these reviews, I'm sure. So they were produced by the clinical evaluation team who worked for the Department of Health and Social Care. So it was that independent clinical review. But we can't use that because we know that new product, as good as the reports were, we can't use them because new products have been brought to the market over the last 4 years. And we also know that some of the existing products that were actually reviewed might have been had their formulations changed, etc. in the interim. So in the absence of this sort of independent objective test data, we know that we're going to have to make some clinical judgments and some clinical decisions around some of these products. But just to show just a brief excerpt here from Absorbency, and then the next slide is on permeability. So we did look at the clinical evaluation team data, and the little red dots in the middle show the average, and the absorbency was measured. It was the total fluid handling that was measured, and it was grams per 10 centimetres squared. And you can see that for foams, it varies quite a bit, depending on whether they're adhesive or non-adhesive, silicone or not silicone, and also as to whether they were used under compression or not. So when used under compression, the absorbency, not surprisingly, was significantly less, and less difference between products. But between the lowest product and the highest product in terms of absorbency, there were quite significant differences in some of these cases. And very similar for permeability as well, particularly there with the silicone non-adhesive foam. So that probably suggests that we need to look in more detail at some of these areas and really, as I said before, look not just at the similarities, but also look at the differences. So in terms of clinical attributes, what are we looking at? So we're looking at things like clinical use, so wound bed adherence. These are things that are really important to a clinician when they're out there in clinical practice, deciding which product they're going to put onto a wound, onto a patient's wound. So things like wound bed adherence, how's it going to adhere to the surrounding skin? What about its absorbency, permeability, hemostasis as well? So these are things that probably, in terms of the classification system, aren't just a simple yes or no. We're looking at a sliding scale from 0 to 3 or 0 to 4 for some of these. Particularly, I think absorbency is 0 to 4. Then there's also things around the environment, fibre shedding. Is it going to leave fibres in the wound? We think about moist wound healing, and we know that in the main, that's what our aim is. But there are some times when we're not aiming for moist wound healing. So that may also be an important consideration. Things like odour control, protease inhibition, which can also be one of those that's particularly controversial. Is it protease inhibition or is it modulation, or are we looking at both? So those sorts of things can cause significant clinical debate. And then also the tissue types and wound types. And this is where we get into most areas will have their own local wound care formulary where they'll advise staff on what to use on certain types of wounds. And this is where we would be looking at those sorts of decisions that clinicians make every day, you know, and apply them to their own wound care formularies. But how can we build these into a system that's going to enable good clinical decision support at the point of care? So our methodology for assigning some of these clinical attributes is, I'm going to pop up 2 slides here. The first one's on people. So we're using this modified Delphi process. So where in round 1, we're going to ask the clinical expert panel to independently, on their own, assign values to clinical attributes. Where there's more than 80% agreement, then we would just accept those fields and populate those within the classification system. But where there's less than 80% agreement, we would then move to round 2, which would be unblinded. So in round 2, they'd be given the same information, but given the information that other clinicians have stated about that particular product group. So they would look at it and feel, do they agree with that or do they disagree? So you would then hope that we'd get more than 80% agreement for some of those that were up for debate previously. And then the remaining attributes with less than 80% agreement, we would go to arbitration via the expert panel group discussion. So we'd get everybody in the room and talk about it, or the clinical reference group that we are using to help us test and design and test the methodology. But where we can't assign values, due to a significant difference between products, that tends to be where they say, well, do you know what, for this particular attribute, it's very much product dependent and no two products in this group really behave in the same way, then we'd be moving to population by product line. So the product line section is going to be much bigger because obviously we need a much larger number of people to try to look at these products at individual product level. So we'd be breaking that down by areas of interest, and we're also hoping to be able to do this using a web-based system to capture this information together with full audit capability, so that we can see who's gone in and put that information in, but that we can manage this process through that. So this is sort of how we're going to tackle the population of those attributes. And we, as I say, we have tested this already with the clinical reference group, made some modifications to it already, but it seems to be working quite well. And there is a lot of agreement between clinicians, which was really good to find about a lot of the products. But there are also some that are clearly very product dependent. So once we populated those and completed the population, then we would be moving on to the consultation stage, and that will go out to all National Wound Care Strategy Programme stakeholders. So we know that our consultations previously have had great responses, and we do look at and review every single piece of feedback. So this will be no different to the others in terms of looking at all of the feedback. And this one's more of a technical slide. So there's some of this that at the top that's going to be going on in the background via the National Wound Care Strategy Programme admin. But our Delphi panel, when we go to that next level of individual product lines, it's going to be a huge number of companies, industry partners that we're talking to, but also lots and lots of clinicians. So we really need to get that process automated. So that's what we'll be aiming to do. And it'll be a bit of a feedback. So the attributes will be populated, and then we'll review the reports on that and to have those discussions and take that forwards. Okay. So our timetable for completion, just wanted to sort of finish with this really. So at the moment we are putting a huge amount of time and effort into the development and the testing of the methodology because we really want that to be right for the clinical attributes. We are going to, we've tested it very much with our clinical reference group, but we're going to be recruiting, hopefully imminently, a representative clinical panel for assigning those clinical attributes. And what we want is a really good mix of clinicians from different disciplines, from different regions in England, and, you know, a mix of community, hospital, burns and plastics, vascular. We want a really good mix of people on our clinical panel to assign those clinical attributes. So if anybody is interested in joining that, we will be sending out information afterwards, or there will be information on the website as well, hopefully within the next few weeks, in terms of how to apply for that position and to be a part of it. And the mapping and the coding of product names and codes to get this one master list, we're well underway with that. That's almost, I'd like to say it's almost there, but I think we are well on with that. So we're confident that that one's going very well at the moment. So Q4, we aim to start moving into the testing of the software for the clinical and technical attributes that I was just talking about on the previous slide. And then we're really, really hopeful that we can get to consultation on some of this, at least on some product groups to start off with, by next April, May time. So that's where we're hoping to be. And then test that process in terms of the consultation feedback that we get. I guess that's going to inform how quickly we go with the remaining product groups. But I guess that's why we're spending so much time now on really trying to get that methodology right. And then finally, we're already working on this to a certain degree, but development of this business case for implementation and hosting of the classification system, because what we want to end up with is this prototype that can be picked up and used. But we're going to need a host for that. We really need one of the NHS bodies to be hosting that going forwards and maintaining the system over time. And just a little one, it does feel very slow and steady, this part of the programme, but it is enormously complex. And one of the things that myself, Anne and Ken always hear when we're in discussions and meetings with people is, oh, wow, this is huge. And we say, we know. It is huge. It does need doing. And we are trying to tackle it, but it, like an elephant, you need to bite one bit off at a time, and hopefully we will get there in the end. Okay, so I haven't seen any chats, so I don't know if there's lots of questions or not lots of questions.
Well, you might be delighted, you might be surprised. There's been a very healthy ongoing chat.
Oh, okay.
And I'm glad that you said that. Oh my gosh. Again, I was thinking, in case anybody's in doubt, this is a hugely ambitious and a hugely challenging program that we're running, but we're game for it. And doing this sort of engagement is very important, and listening to the questions and answers and understanding what people want to know more about is really important to us, so that we do design the best possible system. So we've got this last slide gives me an opportunity to say, if anybody on the call has not yet registered as a stakeholder for our programme, then if you go to our website as displayed on this slide, you will see that we have stakeholder forums for healthcare professionals, for I don't remember if we call them industry, but industry supplier partners, and also patients and carers and the public. And then you will get periodic updates about our programme, and you'll get involved in any of our consultations. You may also wish to follow us on Twitter to keep update with our publications. So I'm going to suggest now that, Nikki, that you stop sharing.
Yep.
And that we ask people, we've got a number of questions that have been raised through the chat, where I'll ask people if they want to follow up on the questions that they've asked, so that we can have a bit more of a discussion. We have 20 minutes, but we don't need to use all of it. And if Nikki's been comprehensive, then we can take it from there. So Ken, do you want to say any general points about the questions before we ask for more, or we start to go back to people who've asked questions for follow-up?
I think from the chat, I think there's a number of outstanding issues that people might wish to discuss in the open forum, or we need to expand on the detail a little bit to understand what the question, what the background of the question is. But no, I don't think there's anything I particularly need to add. I think Nikki has comprehensively covered everything that we can say at this point.
Okay. And Nikki, you've got at least one congratulation for a good update, and that the fact it looks good and robust, which is, given the complexity, it's always nice to it's always nice to see. So if I can pick it up first, and in no particular order, Jill has just asked us about who will be responsible for incorporating new products into the system. And to give you a bit of a break, I'll take this one because some of the others will be more technical. So Jill, Nikki will have mentioned that we will be she'll have mentioned that we're looking for a host, so an organisation to host this. We're in effect doing all of the heavy lifting to develop the prototype, and then we will need to find in the NHS architecture, which many of you will know is rather complex, and many more of you will know, is subject to yet again another change with many moving parts, we will have to agree with colleagues at the Department of Health and develop a business case for this. We will have to agree who is the most appropriate organisation to host the maintenance of a system like this. And one can imagine a number of candidates for that. We could imagine that the people who look after the drug tariff may have an interest in doing this. It may be that people landing in a commercial directorate may have an interest in this. But with the changing landscape, there are a number of bodies, but a big part of our work will be to identify the appropriate national host. And as well as developing, and what we're doing in this prototype is developing the methodology, which then be rolled forward to how new products are classified. And our current understanding of the landscape is the gateway into the market is through the MHRA, and so that the MHRA will be a key member of establishing when are new products coming and how quickly they can be added into a classification system. But bear in mind that just because we are not a program that will restrict access in any way, and so there will need to be a host decides on the frequency of updating, but it'll only mean that you can report on products but not in their appropriate classification grouping, should there be a lag between product becoming available and it being classified. So hopefully, and while we are still holding on to the programme, we will be incorporating new products as soon as when we get the information of their arrival. Ken and Nikki, would you agree that's a fair answer?
Absolutely, yeah, 100%.
And so work in progress. So that's Jill. I can now see that we've got a hand up, and that's Heidi. So if we go to hands up first, and then I'll go back to the chat, if that's okay with everybody. Good morning, Heidi.
Good morning. I think you might have partially answered that the question that I had actually, Anne. I was thinking about sustainability and apologising to all the commercial partners that are on the call, but there have been times over the years where a commercial company has brought out a new product and managed to get its own category to describe the product so that it can have a stronger marketing position. So thinking about sustainability of the new categorizations that you're coming up with, how will companies in the future be able to, will they have to align to the classifications that are given, or will there be a more robust way if they want to create a new classification for their product? And who will be overseeing that?
So if I again take this and then ask Nikki and Ken to, it's a brilliant question. We're developing a system for the NHS by the NHS. We have agreement in principle from the NHS bodies who currently classify wound care products either for clinical decision or for buckets and looking at usage. We have agreement in principle that all of the NHS systems will align with our classification system. And so the classification systems new products will come on, we'll go through, we believe, a sort of Delphi type process with expertise. There's obviously going to be issues for new products if there isn't user experience. So we might have to have a bucket that's called unclassified. And of course, until there's user experience and more evidence, it may be that these products are not able to be built into clinical decision support software. There'll be a lag. But that doesn't mean that it blocks access to the products by use in the NHS, because we're not involved in product access at all. And so but what we're not doing, it will be up to people who have their own classification systems and not NHS to decide whether they still want, because let's face it, many of our providers are international, and it's an international market. And so providers in the UK will possibly not be able to influence. You know, we're not aiming to influence global markets. We are working with the GMDN, who are committed to building into their system to make sure it matches our categories, because what our system will do is get to a lower level of detail than theirs, and there's nothing that they've seen in it that would be inconsistent their approach. And they believe that it may be useful to have further alignment. They're unlikely to go down to the level of detail we are, because it's a different purpose for them. But we won't be imposing this system on anybody outside the NHS.
Mhm.
Nikki and Ken, do you want to add anything to that answer?
Not particularly. I think it's important to appreciate, as Heidi's raised the issue, that we will have to deal with new products, some of which may have innovative technology that we're unpredictable at this point. So we've attempted to make the system as flexible as possible by concentrating on the clinical attributes that every clinician would understand, rather than on a classification that is somewhat arbitrary. And the process of updating is going to be key. It does need to be in line with the weekly or monthly releases that come from existing systems, so that we're not looking at 6 monthly or 12 monthly updates. We're talking about this being a near real-time dynamic process.
I think the other thing we should add in terms of NHS bodies, I've mentioned that in terms of people that use a classification system for their approaches in the NHS, we're also working very closely with NICE and their med tech processes. Indeed, we've got a senior member of NICE on our board, and we know that NICE are looking, well, will always be evolving their med tech, which of course is the body responsible for some of the clinical evaluation goes on, as are the drug tariff team. And the drug tariff team are actually part of our working groups, and we're working very closely with them because they'd have a lot of implementation to do. So they're giving us lots of advice about that. But we need to be aligned across the NHS with all of the processes, hence our being cautious at this stage about where the host might be and who might be the relationships, because unless we bring together all of the relevant bodies, we won't achieve this very ambitious programme, which is to get NHS alignment. But we do think that's worthwhile, and we're having a go at it. So I don't think there are any other hands up. But I think, Paddy, you asked a very important question with regards to the SMTL and the clinical evaluation team's process. I wonder whether it would be helpful for you to maybe reveal yourself and come and ask us and say a bit more about the background to your question, which I think was largely about how much change has there been, and so are those currently in date, which I'm sure Nikki will want to refer to, and include how we might be using them as a reference source, even if they're not the final decision making their own. So over to you, Paddy.
Well, hi, good afternoon. Sorry, good morning. It's still. I just wondered, it's just in terms of the amount of work that went into, obviously, the CET reports, which are across lots of different categories, and those reports. So, and obviously, each products were evaluated to various agreed test methods and standards. So I think a lot of that data is still very valid. And I recognize that some companies may have had new formulations since then, and also there's new products to the market. But I was just trying to determine how many new products have come on the market since those reports. I wouldn't suspect there are many, but there'll probably be, some. And it just, rather than avoid or duplicating and repeating a lot of that in vitro work, which is also quite expensive to conduct, is that original data is still very valid. The test methods haven't changed themselves. It's just that how would, if there's a new product on the market or if a formulation is changed, can we identify where those products are, and therefore the testing will be repeated only in those products.
Yeah, Paddy, yeah, I think you make some really good points there. And absolutely, we've looked at those CETs. They were really good, really very thorough reports, and we've looked at them in some degree of detail, and those are certainly areas that we're using, or certainly reports that we're using to as part of the overall information to try and inform those clinical attributes or the allocation of those clinical attributes. So we are using that, but in terms of how many new products, I don't think we do have that. I think Ken answered earlier on that that is something that we can look at, how many new products have come onto the market in recent years since then, but they are becoming a little dated now. That it's 4 years ago, so we know that there are differences from when those reports were done, but that's not to say that they're not still useful, and we will be using those as well.
Yeah, if I could come in just to mention that the new product rate, or the new formulation rate, as Anne mentioned earlier, the MHRA are probably the most comprehensive source of that information, which Nikki is working hard to get information from them, a copy of their whole record. Probably the most accessible data from a historic point of view we found is coming from the BNF on a monthly basis, and we can go back several years to find out what products were available then as opposed to now. So what part of the plan is to, once we've got our current system with the current data as we wish it to be, is to compare it with some of the historic data coming from the BNF. Preferably, we'd like to also compare it with the MHRA output from some time ago, but that might be technically a bit difficult, to see how many formulations appear and at what sort of rate per month, per year. I get the impression from talking with TVN colleagues that the new formulations, as opposed to new product lines, there's several per month appearing, so it is quite a dynamic area.
I think probably one of the other things, just to add very briefly to that, is that the reports were quite hard to get the information out of. We would have liked it really in an Excel format, which would have made it a lot easier for myself and Ken, but we have done a lot of that groundwork on the reports, extracting the information from it, putting it into a usable format so that we can use it. And we are getting a project officer to join us on the supply and distribution work stream, and we're hoping that she'll be able to take some of that a bit further forwards as well. Yeah.
Thanks, Nikki. So we've got 6 minutes left, probably 5 after I've spoken. And we've got 2 questions that I think we should be raising. First of all, Mike Steele, who's asked about sustainability in green, and whether we can include that in the classification system. I have my own view, and then we're going to a follow-up question about ordering supplies that's come in from Lee. So I'll kick off the green. I think that's a really important future development. I'm not sure at this stage we have enough information to include it, and how we would include it on a ranking. As a national programme, we know that lots of other people are looking at sustainability, so it's a crowded pitch, and sustainability not as in how do you sustain the system, but how do you get to net zero. And as our programme, our priority for net zero is all around the benefits that you get from the clinical pathway and improved healing rates and more virtual consultations and better use of wound management digital systems. So as a programme, when we think about net zero, our major focus is not on products. It's an important issue for us, but we think we can derive most of our sustainability benefits from looking at the work that we're doing on healing rates and workforce productivity. We're getting people healed in 12 or 24 weeks. So they actually use products instead of for 52 or 104 weeks. They only use products for 12 or 24, involving fewer visits. And we think that's a much bigger net carbon impact than looking at choice of individual dressings. given the time, Nikki, do you just want to nod and sound right, or is you're the lead for this? Do you want to add something?
No, you're absolutely right. And just to mention that we did publish exactly pretty much that in the Nursing Times recently. So if anybody wants to go and seek out the National Wound Care Strategy Programme's sort of view on sustainability, it's there. We published in Nursing Times. Do you want me to just pick up on Lee's comment about routes of supply
Brilliant.
very quickly? So in terms of routes of supply, Lee, we did start with the original document that went out for consultation, naming all the online ordering systems. And then following the feedback from consultation, we changed it and removed them all. And I think that was partly because it's an ever-changing beast. So there are new online ordering platforms regularly, and we just felt that it wasn't perhaps right to just put the ones in that were there at that point in time, because it didn't really future-proof the document very well. So we took them all out. I think most people are aware, and certainly the pharmaceutical companies make clinicians aware of the options that there are available, but we did make the decision to take them all out. Okay, so hopefully that answers that.
Okay, which I think it brings us to 11:58.
Yep.
So I think it falls to me to thank everybody for joining. I think we've had some really good questions and comments, some of which we've been able to answer, some of which have challenged and will continue to challenge our thinking,
Yeah.
which is why we want to be doing this engagement. We do think it's important that we are very engaged. We meet regularly with the what's the umbrella term, with the
Trade bodies.
The trade bodies,
Yeah.
to take advice and stay engaged with industry partners. We're working very closely with obviously clinical colleagues in a number of ways. And so I'd like to thank Nikki for a comprehensive presentation, and Ken and Francis for organising everything. And then I think it's time to say goodbye, but you can get hold of us through the website. You can register as stakeholders, so you know where to find us. And Francis is brilliant at fielding questions to us.
Yeah.
So goodbye, have a good day.